CHÉOS exists to improve health outcomes for BC, Canada, and the world. Learn more at chaos.ubc.ca.
Bodanosik, CHÉOS, and SFU. I'm really pleased to present our speaker for today, Chrianna Bharat. Chrianna is a biostatistician and PhD candidate from NDARC, so that's the National Drug and Alcohol Research Centre at the University of New South Wales in Sydney. And for those who don't know, NDARC has been a field leader in addictions research for 20 plus years. It's great to have Chrianna here. She's in her final year of her PhD. Her thesis focuses on applying innovative analytic methods to evaluate medicines use and corresponding benefits and harms among people with opioid dependence using data linkage studies and international surveys.
Thank you, Bowden, Julie, and everybody for joining me today and providing the opportunity for me to come and present. This is my first international trip of the last few years, and it's so fantastic to meet people working in similar areas around the world. So without any further ado, just to flag, the title that I've put up here is the title of my thesis, so slightly different to what was in the seminar leaflets. The content is the same, but just to be able to provide a bit of context of how this work fitted into the broader scheme of what I've been working on as part of my PhD, that was the reason for that. I first want to start by thanking and acknowledging everybody and all of the different institutes that made my PhD feasible, including my supervisors and co-authors. I was very privileged in that all of the data used in my thesis was routinely collected linked data. I didn't have to go out and collect anything. That is a huge privilege and one that I very much acknowledge. So the data custodians and the linkage services are the people that made that feasible. So a bit of background of me. So I am from Australia. I study and am doing my PhD through UNSW Sydney, which is on the far right-hand side. I was living there prior to COVID. As I'm sure many people, things change, things move. I've moved back to my home city of Perth, which is on the far left-hand side. It is one of the most, oh, thank you, so sorry. Great. It is one of the most isolated cities in the world geographically. We have our own marsupial. Next slide, please. Called a quokka. It is known as the cutest animal on the earth, at least among locals. It's on this tiny little island off the coast of Perth. It is not, however, the cutest animal in Western Australia. That goes to my dogs, which are who I miss very much at this time. All right, next slide. So as I mentioned, using big data to inform the treatment of opioid dependence, this is my PhD thesis. And just to provide a bit of background around what that sort of entails. So big data, I mean routinely collected administrative data that is linked at the individual level. In terms of treatment among that, I'll just make it really obvious when I'm like going to tab. Treatment among people with opioid dependence. So opioid agonist treatment for treatment of opioid dependence, but I also have a number of chapters that are looking at psychotropic medicines use. So this is other opioids, benzodiazepines, gabapentinoids, yeah. And then being a statistician, I had a particular interest in the statistical research methods that that I could apply. So in addition to the traditional methods that I use quite often, Cox proportional hazards models, count models, there was a lot of discussion at the time when I was starting my thesis around, and it continues to be now, around the potential for machine learning, artificial intelligence to really revolutionize the delivery of public health. And so as part of my thesis, I really wanted to sort of interrogate that in the context of drug and alcohol treatment. So I know that there are a lot of clinicians in the room. I know a lot of us work in the addiction space, so I won't labor on this too much, but just to provide a little bit of background, opioids are among the world's oldest known psychoactive drugs, with the use of derivatives from the opium poppy recorded for thousands of years. Opioids such as codeine, oxycodone, morphine, heroin work by interacting with the brain's opioid receptors and can change how those receptors respond to pain stimuli. Opioids are used for a wide range of medical purposes and are listed by the WHO as essential medicines for acute pain, pain caused by cancer, palliative care, treatment for opioid dependence as well. Extramedical use occurs around the world, and by that I mean referring to the use of illicit opioids or prescription opioids in means other than how was directed by the prescriber. And many people use opioids for their effects without necessarily choosing or being aware of the risks of opioid dependence. Next slide. So opioid dependence is a chronic mental health disorder with varying definitions across different diagnostic systems. WHO ICD defines dependence as involving a cluster of symptoms involving impaired control over use, prominence of use in a person's life, physiological symptoms such as tolerance and withdrawal. Not everyone who takes or uses opioids, even long-term, develops dependence. There are multiple biological, psychological, social, and cultural factors that interact to determine a person's likelihood of developing opioid dependence. For those that do go on to develop opioid dependence, this can increase risk for a range of adverse events, whether those be health or social, including overdose, reduced quality of life, mental health problems, etc. Okay, next slide. Maybe, yeah. Thank you. So opioid agonist treatment, or what I'll be referring to as OAT, also known as methadone maintenance treatment, also known as opioid substitution treatment, all of these things sort of referring to the same concept or a similar concept. That being a long-term treatment approach to involving the regular provision of long-acting opioid medicines, which help both in preventing the onset of withdrawal and reduced cravings when not using other opioids. It is one of the most effective treatments for reducing harms associated with opioid dependence. Next point. Yeah, in Australia, approved medicines for this indication, and as I mentioned, WHO listed essential medicines include methadone and buprenorphine, as shown there on the far right. And we also have recently, since I published this work, introduced the injectable OAT formulations as well. Both or all of these have, well, both of these have been shown to be effective in reducing illicit opioid use and multiple adverse events, including transmission of HIV and Hep C, contact with the criminal justice system, and also mortality. OAT programs also, in addition to reducing the risks of those adverse events, it can also serve as a means of facilitating contact with other services, so mental health treatment, but also social support, housing support. So retention in opioid agonist treatment. Long-term retention is in OAT is recommended, and it's often used as a core outcome in evaluations of treatment effectiveness for multiple reasons, however, including personal treatment and systemic. Not everyone is retained in OAT, and cycling in and out is not uncommon. We can go to the next one. A recent review of studies, or not so recent anymore, a recent review found investigating retention and factors impacting retention reported wide variability depending on the setting that it was delivered in, but some of the strongest evidence that we have relates to that of the person. So we know those who are older, who have less criminal contact, and those with less illicit drug use generally are better retained in OAT. In terms of treatment-related factors, higher doses are generally associated with improved retention as well. As we look to improve retention for people using these services through alternate forms and alternate models of care, we also want to consider sort of other innovative approaches. And one of these being a more integrated approach to both the assessment and stratification of care, in which treatment plans can be personalized and tailored to an individual's needs. So with that, that had us asking the question, next slide, can we predict how long someone will remain in OAT? Being able to identify those at highest risk of early cessation could provide actionable information, highlighting the need for more intensive engagement and potentially also adjunct support at treatment initiation and stabilization stages, which in turn could improve retention. So we had 3 aims. Oh, so good at this. First, we wanted to summarise retention in OAT among new entrants to the New South Wales OAT program, New South Wales being the state in which Sydney is based. Second, we wanted to develop a model for predicting retention in OAT. And in order to do this, or for such a model to be able to be delivered at the population level, it would need to be developed using predictors which are routinely collected, hence the use of routinely collected data. As I mentioned, I also had an interest in examining the potential of machine learning, and so the second component of this aim was the comparison of traditional and machine learning models for developing this predictive model. And finally, the third aim, in routinely collected data, there are the known and unknown factors which impact retention, which are otherwise unavailable in that routinely collected data. What we wanted to do was examine how the application of sophisticated machine learning methods to detailed temporal health service use, so looking at the longitudinal pattern with which somebody engaged with the health service system, if we could identify novel proxy measures for predictors of retention from that information. That is a lot to process. I will break that down. So with that, we'll now turn to the data. I'm behind you now. So data for this study came from the OATS project, that is the opioid agonist treatment safety study. It's a retrospective cohort linkage based in New South Wales, Australia, which contains records of all OAT prescribed and dispensed in any setting between 2001 and 2018. To provide a little bit of background of the OAT program, methadone maintenance was first established in the 1970s, and it was in August 2001 that buprenorphine was introduced into the program. So this means that this linkage is a population-based summary of OAT over a 17-year period since buprenorphine was first integrated into the program. So a really, really rich resource. We linked OAT records to statewide admin data sources recording information on health service use. So that included hospitalizations, emergency department presentations, and community-based mental health outpatient data. And just to address the history of OAT there. So the spine was defined as anybody who received OAT between 2001 and 2018. But for those people, if they had been in OAT prior to 2001, we have all of that information as well. And that's pertinent to the next part of the analysis that we'll be talking about. Hopefully you can hear me okay. Where are we at? Yeah, criminal justice, thank you. So we have information on criminal charges as well as periods of time spent in custody. And then we also have information on mortality. So that included cause of death and also National Death Registry information. So for my study, we wanted to predict or develop a model that predicted retention at first entry into OAT, so people who had never previously been engaged in OAT. So from that entire linkage study, we identified the subset who between 2001 and 2018 had never been in OAT before. So that's where that prior OAT information became important. So that at least in the New South Wales OAT program, never engaged in OAT. Okay, outcome. So talking about retention, we're talking time to cessation. And for this particular study, this was in their first episode. We defined the episode as continuous treatment with no more than a 6-day break. There are nuances in how the OAT data is recorded. So for somebody to receive OAT, they need to be given approval, or they need to receive approval from so the prescriber fills out a form that is sent off, they then receive that approval. And it is the dates of those commencements and ceasing OAT that are used to define these episodes. And so where there was, say, a close of an episode that may have been then followed by a change in medication that occurred within a 6-day break, we considered that a single episode. And we censored episodes for the prediction study at 12 months after OAT. So 12 months is often used as an indicator of, or sort of the minimum threshold of OAT. It's a very sort of soft outcome in that sense, but at least in terms of wanting to ensure that somebody could, people who would be considered to be ceasing early, we define that as a 12-month engagement with OAT, and otherwise censored at end of follow-up or date of death. Okay, so to provide a little bit of an overview of the cohort characteristics, so we had just around 16,500 people who commenced OAT for the first time between 2006 and 2017. So even though we had information going back to 2001, ED data wasn't available up before 2005. So for this particular study, we're summarizing or predicting people who entered OAT between 2006 and 2017. But for some of this overview of retention that I'm about to give, I'm doing it from 2001 onwards. The majority of entrants were male, were not Aboriginal or Torres Strait Islander, though 25% is disproportionately high compared to the general population. Most lived in a major city. Almost half had presented to an emergency department in the year prior to entering OAT. A third had been admitted to hospital, and a quarter had received mental health care in the community. And we can see from the right-hand side there that the number of new entrants into OAT was highest in 2001, but sort of averaged out around sort of 2005. There was a recruitment spike in 2010, which is what's going on there, but approximately sort of between 1,250 and 1,750 people per year entering OAT for the first time. In terms of treatment characteristics, so here we show the distribution of OAT medication by year of entry. So if you remember, the buprenorphine was only available from August 2001. So in 2001, far more people started on methadone than bup. But in the years since, it's sort of averaged out to sort of equal choice of the two medications, though in the more recent years, bup becomes the more common first choice. And while initial investigations revealed higher retention in buprenorphine compared to methadone, yeah, we can go. Perfect. When we dug into that a little bit more, we found some interesting differences. So, next slide, please. Here we have, there's a lot going on in this slide, but it's essentially 3, 6, 12, and 24-month retention rates by year of first OAT entry and by medication type on entry. And we found that retention by medication had changed over time. Specifically, we found that the difference between buprenorphine and methadone retention in people's first episode reduced with time since integration of buprenorphine into the OAT program. So consider 12 months, for example. New entrants, retention rates for 12 months among new entrants, for those entering into buprenorphine, almost tripled over the follow-up period of this study, from 16.6 to 46%, compared to over the same time frame an only 2% increase in methadone for 12-month retention. Similar trends were also observed for across all episodes. So these here, we're talking about just first episodes, but looking at all episodes combined, similar trends were also observed. So I'm rolling around here, sorry. So with that, we wanted to examine the factors that impact retention. So we identified variables from the data based on evidence regarding OAT retention and the availability of those variables in the administrative data. So we define a range of demographic, criminographic, treatment, and clinical history variables. And these were what were included in our traditional Cox model. Looking at what we found, so next slide. You can hit one more. Yep. So A separate study focused on how factors of or characteristics of the OAT prescriber impact on the retention of the client. So we found some indication that longer tenure of OAT prescribing was associated with improved retention. This could be attributed to the clinician's ability to be able to respond and adapt clients' treatment to their needs and based on how they're responding. It also could be that at least initially, the use of, we'll stop there for a second. So longer tenure, more experienced prescribers being able to respond to what their clients were needing in terms of their dosing. In terms of the settings, we found that those who were receiving OAT in justice health settings were more likely to be retained than those in the public health sector. Those who'd spent more time in prior treatment episodes were associated with improved retention. So these analyses were looking at all episodes, but analyses were similar again with first episodes only. And as we saw previously, we found that there was decreased retention associated with buprenorphine versus methadone. However, this effect varied by cohort. So even in the most recent cohorts, there was still a slight difference in retention among those entering in bup versus methadone, but far less than it was in the first few years following its introduction. Next. So we found that persons with substance use and mood disorders were associated with improved retention. Important to remember how these values or these indicators were evaluated. So these were people who were receiving treatment for these mental health disorders. So they'd either been to hospital or been in mental health community care for these treatments, for these disorders. Conversely, we found, similar to the existing literature, people with more criminal offences, those who were younger at entry, and also indication that those with schizophrenia were associated with poor retention. So yeah, keep a snapshot of that in your mind as we move forward. Just to go back one more, sorry, there was one thing I just wanted to mention. Just in terms of the effect of buprenorphine, especially after speaking with Bowden very briefly just before about some of the trends that you guys are seeing in retention around here, which not to say that this is the reason, but some of the explanations for that, and they are largely just explanations, are that at least initially when buprenorphine was integrated into the program, there was an indication that it was, or there was a perception that it was better suited for withdrawal rather than maintenance treatment. There was also the anecdotal reports that the doses that were advised for use of buprenorphine, which were initially modeled off methadone, provided suboptimal therapeutic effects for their clients. We saw that in 2006, so 5 years after bup was first integrated and the first set of guidelines were provided, the dose thresholds were changed, and in the time since, retention in buprenorphine has really improved. That's important to note because the OAT data in New South Wales does not have detailed dose information. So this is not something that we can empirically test. It is also not something that we can include in our analyses, which is really unfortunate, but something to potentially explain that effect that we're seeing at least. Okay, all right, next slide now. So remembering again that these were the predictors that were included in the Cox proportional hazards model. The deep learning model included all pre-specified predictors from the traditional Cox model, except for, next slide, except for the comorbidity and emergency department variables. So the demographic, criminographic, treatment related variables were all consistent. Instead, what we did was, next slide, remembering the want to interrogate the health service use in a little bit more detail. So often a lot of the comorbidity factors that we define in our models will say, is there, for example, past year evidence of depression? And then we create a binary indicator for depression, yes, no. There is the potential that that loses a lot of information, and it also requires us to know which variables we want to be able to define or create indicators for, right? So there are methods in the literature that we could apply that took that detailed information and tried to input that into the model, which is what we were doing here. So if you consider the time that somebody enters into OAT, and then 1 year prior to OAT entry, we then, you can toggle a couple of times here, thank you. We then looked at where they had received treatment from, what they had received treatment for, and how long between each of the visits it occurred. So there's sort of 3 detailed pieces of information that we get from that. The diagnostic codes from those visits were represented as high dimensional real valued vectors. That is a lot of words together. I'm going to call them embeddings. So that embedding, which in here over on the far right hand side in the pink, is just, if you imagine a vector, and it's just all of those codes sort of lined up. We took that information, we combined it with the type of code or where it came from, which is that yellow vector there. So that would be whether it was ED or community-based, whether it was hospitalization, and then also because of the variation in some of the coding systems used across these different systems, that was also captured in there. And then the little blue box at the bottom also captures the time difference. So a overdose that occurred 11 months prior to entering OAT, that, and say an overdose that occurred 1 month prior to entering OAT, that nuance is captured in these embeddings. Are we following with that? Okay, don't flick yet, sorry, thank you. So we've done that. So we've got those code embeddings, we've got the type embeddings, we've got the time component. Those embeddings are essentially combined. We process that through a single bidirectional long short term memory layer. An attention network is another way of calling it. And from that, it provides an output of a single vector representation. So looking at that vector, you would, even if I explain what was going on, you probably wouldn't be able to tease out what's going on. But it's trying to, in a high dimensional way, capture the detail in that pattern of health service use prior to entering OAT. Okay, I'm seeing nods. I'm hoping that we're okay. It's okay if you don't. The concept is hopefully there. I'm flicking because I'm behind now, but yeah, so this slide, great. Okay, so this is the same figure that we saw just on the other side. I've just shifted that over to the left-hand side here. So we've got this single vector output, which is the representation of health service use. Next. We then combine that with the pre-specified predictors. So those are the demographics, the treatment, and the criminographic factors that we specified on the previous slide. Those are combined with the attention pooled outputs, processed through a neural network, and their output from all of that is a single numeric value, just a single value. And from that, that forms the, if you click twice, so this is the formula for a Cox proportional hazards model for those that are familiar. And all that this deep learning network does, what this deep learning network does is it's taking all this information that we've talked about, compiling them, processing them through, trying to come up with this sort of high dimensional representation of what's going on. And then the single numeric value is input into that highlighted yellow component of the Cox proportional hazards model, which is usually where we put the linear combination of predictors. So when you would have, you know, your beta age plus beta treatment type, blah, 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 blah. So instead of that, we take this numeric output, it forms the log relative risk in the deep learning survival model, inputs there, and the survival analysis fits otherwise similarly. So if you were to ignore the schematic that we have here, that's very distracting, you could, if you have that single output, you would be able to fit this survival analysis in the same way that you would do every other sort of Cox proportional hazards model. And the associations of individual diagnostic codes with the outcome can be described using an estimated hazard ratios, and those that estimate comes from the weightings of the neural network that are processed through. Okay, and I'm very happy to share the original methods paper, and then this work is also published, so there's a lot more detail that can be gone into for those who are so interested. All right, next slide, please. So I've talked very broadly about different methods so far. Cox proportional hazards model, I hope people are familiar. Here I'm talking about the methods of developing and validating the model. So there are a lot of hyperparameters that are required to be tuned for fitting these deep learning models. So we reserve 10% for network optimization and use the remaining 90% for training and testing using a 5x2 cross-validation approach. And it was the same training and test sets that we used to evaluate the traditional and the deep learning methods. In terms of performance evaluation, we used a range of both quantitative and qualitative measures, just to be able to get a sense of if there was any variation across these different measures. And next, okay. So on to the deep learning results. So here we have the predictors that were the same between the traditional and the deep learning model. And overall, the associations that we observed were comparable to those in the Cox regression. We use this kind of as an indication of if something was going drastically wrong and these were wildly off, then that would be concerning. But we found improved retention among males. Younger age was associated with worse retention. This is summarized. Buprenorphine was associated with poorer retention. Sorry, the hazard ratios, I'm reading the wrong way. Males were associated with increased cessation risk. Buprenorphine was associated with increased cessation risk. Yeah, we can go into details of those a little bit more. But what we're really here for is the deep learning detailed results. So this might be a bit small, but I'll try to flag the more interesting points. So these are the local hazard ratios that came from the deep learning model. On the far right, those are indicative of poor retention. On the left indicates improved retention. Okay, we'll need to work in tandem here, so click once. So we found that schizophrenia was associated with increased cessation risk, while mixed anxiety and depressive disorder were associated with reduced cessation risk. So thinking back to the results that we found in the original Cox model, we had indicators of schizophrenia and anxiety and depression. We found that schizophrenia was associated with poor retention and anxiety and depression with improved retention. The way that they're defined is slightly different because these are specific codes, but it is encouraging at least that in that way these results were consistent. Okay, click twice. Thank you. So interestingly, we found that the codes for treatment for harmful opioid use were associated with poor retention, while treatment for opioid withdrawal and treatment for opioid dependence were associated with improved retention. This sounds a little counterintuitive. The way that I try to make sense of this, I would think that treatment for opioid withdrawal, and it could be that these are indicators of proxy measures of severity, right? So somebody who's already trying to withdraw from their opioid use or who has opioid dependence versus harmful opioid use may be indicated of more severe opioid dependence, in which case may be something that they're more willing to engage in at that point if they're seeking treatment for these symptoms, remembering again that these are all codes that are used, that are coming from having engaged with health services. But very interested to hear others' thoughts and talk about that a little bit more. Click twice again. We found evidence that personal history of medical treatment non-compliance was associated with poor retention. One more click. Thank you. We also found that homelessness was a significant predictor of reduced OAT retention. Despite consistent evidence in the literature around Wow, time has flown by, sorry. Despite consistent evidence in the literature of decreased access to oat among people with unstable housing, there's actually been really mixed evidence around the impact of, once engaged in oat, the impact of homelessness or unstable housing on retention. That being said, I think even if housing instability wasn't necessarily an important predictor, treatment models that focused on reducing barriers to engaging in oat and remaining in oat could be helpful to even those that may not be experiencing homelessness, but just breaking down those barriers of remaining in oat. Other associations of note, non-admitted treatment for drug use disorders. This is remembering a community-based sort of lower threshold treatment, and it's also very wide in its capture. It's literally all drug use disorders, a limitation of the way that they've captured that data. And we also found evidence of abdominal pain was associated with improved retention. Something around the impacts of opioids on the physical body, maybe. But again, that was a little bit surprising. Okay, performance metrics. This is the bit that we're all sort of interested in, or at least for me, it was the most intriguing. In terms of the qualitative evaluations of calibration and discrimination, we didn't see any sort of notable differences between the two measures. If they're sort of aligned on that sort of x equals y angle, then that's sort of a good indication. However, the quantitative measures revealed a different story. So for the measures seen here, all were marginally better in the deep learning model compared to the traditional Cox model, as highlighted in bold. However, using that 5x2 cross-validation approach, we also found no evidence of a significant improvement in the deep learning model. When I think about the complexities of fitting these models, I had to buy a new machine to be able to do it. It took a lot of time, even sort of creating these embeddings. It was a great learning process, but definitely sort of different computational way of going about sort of data formulation. It does raise the question of whether in this particular scenario that was worthwhile. This was somewhat, sorry, back one more. That's okay. It was a little bit disheartening, especially considering some of the other results that have been found when comparing traditional and deep learning approaches. But the actual performance measures shown here are not particularly good, even for the traditional Cox. So it's not even that deep learning wasn't necessarily better than traditional, just overall, this prediction exercise was not particularly successful, which really raises the question of whether the focus on trying to improve oat is better targeted at sort of population level impacts or interventions that could improve retention, rather than sort of trying to predict at an individual level how likely someone is to remain in oat. Also, a huge consideration in fitting this model is we were using data at the time of oat entry. 12 months is a long time in a person's life. A lot of things go on in that time frame that would otherwise not be captured in this model. And so perhaps a better approach would be a dynamic model that looked at sort of predicting in the next month at each point along the treatment pathway whether somebody was going to be remained in oat. So some things to think about. I might actually skip over that slide and just jump to limitations if time permits. So in terms of the sample, New South Wales oat program, there may be differences found both in associations, but also the predictive performance in other settings. In terms of data, there's the possibility of coding errors and also an inability to be able to validate the measures that were captured. In particular, thinking about sort of the Z codes, which are codes used for other conditions that aren't necessarily being treated at that point. I would suspect that those are probably coded in evaluations that are more intensive, right? So people who need more sort of holistic or broader than treatment for exactly what they're presenting at that particular time. So something to think about there at least. In terms of implementation, external validation and prospective samples would definitely be required before this could be implemented in practice. And then the big one, these are predictions and not causal associations. So even if we could identify a really good prediction model and the factors that impact that prediction, they don't necessarily serve as ways that we could intervene. So there are some interesting methods being investigated in the machine learning space that sort of integrate causal associations into the model. There's also some really interesting work that I think that could be done using traditional methods applied to routinely collected data to be able to get proper causal associations from observational data. Conclusions. If you click 3 times, that will get us to the end. So no improvement in deep learning compared to traditional Cox regression in this particular scenario. We did identify a few diagnostic codes that were not specified in the traditional regression model, which might be things to think about as we model retention moving forward. And addressing structural issues at the population level and considering alternate models of care may be efficient, more effective strategies, just different ways of trying to tackle the same problem rather than trying to get at the capture the individual variability and the things that go on in a person's life as they engage and cease treatment. Thank you. I went a little bit over time.